सो हेलो एवरीवन। आज हम पढ़ेंगे कि रेडियोथेरेपी व्हेन डू वी डू रेडियोथेरेपी इन ब्रेस्ट कैंसर्स। ओके, रेडियोथेरेपी इन ब्रेस्ट कैंसर्स। ओके, सो रेडियोथेरेपी करते हैं हाउ एंड व्हेन वी विल गेट टू नो। So indication: when we get positive lymph nodes, we get enlarged lymph nodes. So we do radiotherapy and T3 at T3 level. So T1 was less than 2, T2 was 2 to 5, and T3 is more than 5 centimeter. So tumor more than 5 centimeter, locally advanced breast carcinoma LABC, we do radiotherapy, and after breast conservation surgery, it is a must that we have to do a radiotherapy. So in case of pregnancy, uh, absolute contraindication is breast conservation surgery because we have to do radiotherapy. So we won't be doing it. Okay. So, so what are the types of radiotherapy? See, whole breast irradiation, WBI, whole breast irradiation. The whole breast is irradiated with radiations. Okay. So what will be the target site in this? Full the breast. Okay. Lymph nodes, axilla, infra, and supraclavicular plus internal memory areas. Okay. And what will be the duration of this? It will be 25 days. Okay. This will be 50 to 55 days. Okay. See, we are radiating the whole breast. So we will be needing more radiation. Radiation exposure is increased. So it is less preferred, but yeah, we will get to know when it is preferred. And accelerated partial breast irradiation, first was WBI, whole breast irradiation, and it was accelerated partial breast irradiation, APBI. The partial breast is irradiated only the where only the area with lesions. Okay, area with lesions is irradiated. It will be 5 days. So the radio will be for 5 days. How much radio will be? 30 to 34. It will be 50 to 54. What will be the indication of APBI, accelerated partial breast irradiation? So T1 says that is less than 2 centimeter. Okay, ERPR positive. See, this is it has got a good prognosis. So T1 is irradiated with T1 less than 2 centimeter tumor is irradiated with accelerated partial breast irradiation. ERPR positive. Okay, negative lymphovascular invasion. We see these are usually good tumors with good prognosis. Okay, so it has good prognosis. Okay, so T1 less than 2 centimeter, ERPR positive, negative lymphovascular invasion. The lymphovascular invasion is not done. Okay, it is unifocal and negative margins. Okay, and more than 50 years. So these are kind of good prognosis one factors. So we will do APBI, accelerated partial breast irradiation. So how is APBI done? See, this is a lesion in which electrodes are placed in the cavity and we do the radiotherapy. Okay. So this was only the radiotherapy, and now we will be talking about other modality. Yeah. Okay. So before I go to other modality, we have treatment options for breast cancer. Radio, we have talked about. HRT, मतलब HT, hormonal therapy, chemotherapy, and surgery. In surgery, we have breast conservation surgery and mastectomy. Okay, so this is a kind of mind map I'm creating for you. So what are the hormonal therapy? Let's talk about hormonal therapy. Indication: either or both ERPR positive. Okay, either it is ERPR positive, ERPR and ER positive. Okay, so there will be the two categories in this. First will be the premenopausal and postmenopausal. In premenopausal, I have talked about that risk factor decrease decreases. Okay, when there is risk, the risk factor will be decreased. In case of bilateral mastectomy, bilateral salpingectomy plus oophorectomy, and other one was SERM, that is tamoxifen. Okay, So in this we will be talking about premenopausal female. This is pre-menopausal female, and breast cancer is all about estrogen. Okay, so we will be giving selective estrogen receptor modulator, tamoxifen. Okay, duration will be for 5 years. Okay, in some cases can be extended up to 2 years. What are the side effects? The most common side effect: hot flashes that are common in postmenopausal. See, premenopausal has increased estrogen and increased progesterone, but postmenopausal has both we get both estrogen and progesterone are decreased. So, in postmenopausal, we get hot flashes due to this. So, this will be the reason, because these will get in decrease. The most common side effect will be the hot flashes. Okay, she will be feeling cold, है ना? Cold and kind of palpitation, sweating, much, to the much extent. Okay, endometrial hyperplasia. Okay, and DVT. And postmenopausal may we give aromatase inhibitor. Aromatase convert the normal androgens to estrogen. So we will be giving aromatase inhibitor, thus decreasing the level of estrogen. That is done by letrozole and anastrol. Okay, letrozole and anastrol. Letrozole and anastrol. This will be given for 5 to 10 years. Most common side effect will osteoporosis. Okay, before starting aromatase inhibitor, baseline DEXA scan is done. Okay, why there will be osteoporosis? So due to this, we will do DEXA scan. Okay, if low, start vitamin D. See, since DEXA help us to get the bone density. So if there will be low bone density, there is no use of doing this. Okay, so if DEXA scan shows low bone density, we have to start with vitamin D, calcium, and bisphosphonates. Okay, these are given. Okay, planning pregnancy while treatment on tamoxifen. Tamoxifen is a SERM. Most common side effect is hot flashes. Okay, and women with breast cancer has this. So how will go about it? See, tamoxifen is tamoxifen is given for 5 years. So suppose a young female comes and uh, she has to deliver. She is planning for pregnancy, है ना? She is planning for pregnancy. How will you go about it? First, tamoxifen has completely taken for 2 years. See, out of 5 years, only 2 years we have to take for tamoxifen. If patient wants to conceive after 2 years, no distance. Oh no, no. No. See, if she is planning, so tamoxifen is stopped 3 months prior. Okay, we advise her to stop 3 months before she wants to get pregnant. So suppose she is planning pregnancy in January, okay, or in June. We will say 3 months prior. That is in March. You have to stop tamoxifen and go about for pregnancy. Okay, and see, tamoxifen is taken for 2 years. Okay, after 2 years, there must not be any distinct metastasis or any other contraindication. Okay, now let's talk about the prognostic factors. What will the prognostic factor? How will the prognosis be? The prognosis will be most important prognostic factor will be the axillary lymph node. What? Axillary lymph node status. In metastatic breast cancer, ER/PR positive. Okay, so axillary lymph node status will be the important factor, and in metastasis, ER/PR positive will be ER/PR status will be the most important factor. Poor prognosis means poor prognosis. What? How will we go about poor prognosis? Poor prognosis. Disease factor. See, poor prognosis means despite giving the medication, the size of tumor is decreased, the stage is increased, lymph node involvement is there, grade of the tumor is increased, histopathological variant. Okay, the histopathological variant. Metas- Metaplastic carcinoma is aggressive. The histopathological variant is seen. This metaplastic carcinoma, that is HER2 positive and triple negative. TNBC, triple negative breast cancer. TNBC. Presence of lymphovascular invasion, excessive DIC component, and high Ki-67. This is the marker of proliferation. Marker of proliferation. Okay. Presence of lymphovascular invasion, HER2 positive. These all are bad tumors. Okay. HER2 positive, triple negative, presence of lymphovascular invasion, extensive DIC, and high KIT. Okay. And what will these are the disease factor. Poor prognosis. Patients का है ना? What will be the patient factor? Suppose the breast cancer starts early, so it has got more of basal type. It will be the basal subtype. Basal subtype as in familial. Familial basal subtype means TNBC, triple negative breast cancer. It will be young age group, premenopausal, BRCA associated. That is familial, family history of breast cancer, prior history of breast cancer, obesity, senile failure to complete intended treatment. Okay. Follow up. What will be the follow up? For follow up, we have to go about. See, we are giving the chemotherapy, hormonal therapy, and chemo. So follow up will be as in for clinical visit every 3 months for first 2 years. Okay, every 3 months for first 2 years. Every 6 months. Okay, every 3 months for first 2 years. Okay, it will be like every 3 months means four visit in a year per year. So we will get total 8 visits. Then every 6 monthly visits. Okay, means two visit in a year. Okay, 2 visits in a year, and every year then 5 visit. Okay, so it will be for 10 years. It will be like for first 2 years every 3 months, 3 monthly. For 2 to 5 wala portion we have every 6 monthly. For 5 it will be every yearly. Examination we will go. What we will do? We will do physical examination in every visit. Okay, we will do physical examination in every visit. Hmm. Mammogram is done. Mammogram, what is mammogram? It is done in elder females more than 40 years because of high fat content. Fat increases and glands decreases. Okay, and USG is done. Patient on tamoxifen, USG pelvis is also done to check for endometrial thickness. Okay, or serum marker is C serum 1513. Okay, so treatment summary will be like surgery. We have breast conservation surgery. If no breast conservation surgery is acinital lymph node biopsy first. Breast conservative surgery contraindicated, then we do mastectomy. है ना? Okay, BCS, mastectomy, and acinital lymph node biopsy. For chemo, see, T1 or T2, N0 या N1, and metastasis absent. These are good. These are good. Good tumor. Okay, small size, plus minus. What will be the plus minus? I will let you know in this. Uh, 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 yeah, plus HER2 new negative. At that place it is given wrong. Plus good tumor, no? Plus minus ER PR, minus HER2 new. Okay, HER2 new negative. Hmm. So it will be We will go for molecular test. Low risk, then avoid chemo. High risk, give chemo. Low risk of what? Low risk of recurrence. Okay. And TNBC. TNBC is triple negative breast cancer, HER2 positive. Hmm. Then we have to give chemo. We have to give chemo. For radiotherapy, we will what are the indication? Indication will be breast conservation surgery and lymph node status. Hormonal ER/PR positive is the main thing that is required. That is ER/PR positivity. Okay. So LABC. Okay. That is locally advanced breast cancer. Okay. For locally advanced breast cancer, the criteria will be, what will be the criteria? See, T3N1M0. Okay. T3N1M0 means Na T4. T4 is all about inflammation. Okay. Or T4 is about T3 more than 5 centimeter. Lymph node, level 1 lymph node, ipsilateral, mobile. Okay. Ipsilateral, mobile, axillary lymph node. Okay. M0 is metastasis 0. Any T4. T4 is T4A B. A means only the muscles and bones. Ribs, hmm, muscle, intercostal muscle, and or T4B is skin. Any N2, node 2 means ipsilateral. Then node 2 is, what will be the node 2? TNM's classification. I have just learnt it. How can I forget it? Ipsi mobile, है ना? It will be mobile ipsilateral lymph node, fixed presence of internal memory, है ना? Ipsilateral lymph node, internal memory, okay, and ipsilateral infraclavicular, internal memory plus axillary, okay. So this is it. What will the management? Hmm. N2 is N2 ipsilateral fixed axillary lymph node or ipsilateral intercostal lymph node. For N3, we have also done that. So, what will be the treatment option? Neoadjuvant chemotherapy plus surgery. Surgery will be breast conservation surgery. Okay, neoadjuvant this will decrease the size. है ना? For this, size will decrease. Then we will go about surgery. Then radiotherapy. ER/PR positive hormonal therapy. If it is HER2 new positive, trastuzumab is given for 1 year. Okay. For what will the metastatic breast cancer? Criteria is M1, that is either metastasis is present or not present, then it is M1, not, and it will be M2. Management will be palliative, depends on the person to person, and olaparib is used if BRCA is positive. Okay, then we will go about ER/PR, HER2 negative, TNBC, and HER2 positive. ER/PR, ER/PR positive, and HER2 negative. Then we will do hormonal therapy. Okay. Plus palbo C slib, ribociclib, abemaciclib, abemaciclib. If resistance develop, we will do chemo. Sodalex, and fulvestrant for TNBC. Okay, triple negative breast cancer. Triple negative breast cancer. We will do chemo first, then we will do PDLI, pembrolizumab, and atezolizumab. HER2 negative. We will do first chemo. Okay, what we will do first chemo, then trastuzumab. If resistance develop, lapatinib, oral HER2, oral anti-HER2, anti-DN. Lapatinib is management of special case type of HE breast. Pregnancy associated breast cancer. Criteria: breast cancer during pregnancy or within 1 year of delivery. That is ERPR negative and aggressive tumor होते हैं. Okay. Diagnosis is by true core cut. That is the investigation of choice. We will do. Sorry, this will be the and investigation of choice will be ultrasound. And for management we will go about first we will do surgery. First step will be the surgery, breast conservation surgery in first and second trimester because we have to feed, then radiotherapy after delivery. Okay, mastectomy. Okay, mastectomy in first trimester. If it is there, then second we have management option is chemo. Contraindication in first trimester. Chemo is contraindicated in first trimester. Okay, safe in second and third trimester. So what about chemo? First trimester में we have to contraindicate this chemo. Okay, and second and third में we safe. Or what about hormonal therapy? Contraindicated and radiotherapy all on all trimesters. So surgery in about first trimester we will do mastectomy. Second and third trimester we have to do breast conservation surgery. After breast conservation surgery we do radiotherapy. Bilateral breast cancer, bilateral breast carcinoma. What will be it? Bilateral breast carcinoma. Usually these are bad cancers. That is, we have familial association is present. That is, familial association is present. That is, BRCA. That is BRCA. Okay, and these are lobule histology. It is lobular. Okay, so diagnose if diagnosed at same time both stage separately. Okay, so if it is diagnosed at same time, we have to diagnose. We have to do it separate. Okay, treatment governed by more advanced aggressive cancers. Okay, treatment is in that way. For male breast cancer, see BRCA1 and BRCA2. For male, it is all about BRCA2. So yes, this is it. BRCA2. Obesity is an important factor. Klinefelter syndrome, alcohol intake, liver cirrhosis. Liver cirrhosis is about gynecomastia. Hard lump is present by diagnosis is by biopsy. So what we will do in this now we have ductal carcinoma in situ. It is ductal carcinoma in situ is kind of non-invasive cancer. These are of types, various types: papillary, cribriform, solid, comedo. P PCSC, PCS, then C. Papillary, comedon, cribriform, and solid. Papillary, cribriform, solid, and comedo. These first three, PCS is ERPR positive. Okay, that is ERPR positive and have microcalcifications. Comedo is a cancer with necrosis and is the most aggressive type. It is like commando. It is aggressive. ERPR negative presents at slump. Okay, these are various micro classification in this. Diagnosis of DIC. Okay, diagnosis of DCIS is a image guided radio biopsy. On management, we have surgery. Surgery will be simple and breast conservation surgery. For simple, we will do simple mastectomy and conservation surgery followed by FOLOET followed by radiotherapy. Okay, breast conservation is surgery if it contraindicated is if there are extensive microcalcifications. Okay, there is no role of chemo in this. Okay, it does not respond to chemo and it is uh, hormonal is ERPR positive. Okay, so for DCIS, there is an index known as Van News Prognosis Index. Okay, Van News Prognosis Index. The parameters are size, margin, grade, and necrosis and age. Low for low score, radiotherapy can be avoided. For intermediate, radiotherapy is given. For high score, mastectomy is done. Mastectomy is done. So parameter are size. What will be the size of tumor? Okay. Suppose this is the size. We have margin. Then it suppose I may make it in the form of G. Okay. So size, margin, grade, and necrosis and age. Okay. ERPR LCIS lobular carcinoma in situ. Lobular carcinoma in situ. It has various features. Now classified as risk factor for carcinoma. Okay, है ना? जो lobular carcinoma in situ is classified as a risk factor of carcinoma of breast. Okay, 1% risk of 1% each year is the risk of conversion. It is bilateral. Okay, usually bilateral plus multicentric. What is multicentric? See, it is multicentric. Okay, this is multifocal. It is ERPR positive. Usually an incidental diagnosis. Patient is kept under surveillance, progression. LSIS, no? Lobular carcinoma in situ, it can transform into invasive ductal and invasive lobular. Either it can invade the duct, invasive ductal, or it can be invade lobule. Bilateral multicentric. E-cadherin mutation is present. So, Indian or single file pattern is observed on histopathology of invasive. Okay, and E-cadherin mutation is present. Note, what is the note? SCDH gene mutation due to